Yes, you're still watching TVC Breakfast. We're now going into this very pivotal conversation. Now, Lagos State is taking a major step in the fight against HIV/AIDS in a bid to strengthen HIV services and improve community health. The Federal Ministry of Health, together with the Lagos State Ministry of Health and support from the United States government, is launching the ART Impact Survey across the state. Now, AIS is a nationwide health assessment designed to strengthen HIV services, expand access to testing, and improve the overall health of communities. Now, trained field workers carrying official ID cards and AIS kits will visit selected households in all 20 local government areas, giving residents a safe and confidential way to know their HIV status at home. Joining us for this conversation is Lagos State's AIDS Program Coordinator, Dr. Oladipupo Fisher. Good morning, Mr. Fisher. We're eating a lot of fish on the show this morning, right? Good morning. How are you doing? It's a pleasure to have you on. This is a very fantastic topic, and I'm happy that, Lagos State is coming out with this very, I would say amazing initiative. Oftentimes, people do not want to go to hospital, to test, because they tell you that if I go and it's positive, then the people know me. For me, that's been a conversation. People always tell me that, really, I don't want to go. What about if it's positive? And that has hindered a lot of people from even checking if they have HIV or not, which is very bad, because we know that with HIV, if you're able to detect it fast, it would not get to the state where you are now in serious problem. So this is a beautiful initiative, but I want you to quickly take us through this ART. Who brought about it, how long is it going to last, and how impactful do you think it's going to be? But most importantly, I need you to explain it to the layman that doesn't even understand what it's about. Okay, thank you for having me. I want to start from the first point you raised concerning the testing, why we have apathy towards HIV testing. The honest truth is the fact that there is confidentiality in the testing. When you go to the vaccine, you and the trained counselor testers that are providing these services. And then, of course, when the result is to be shared with you, and then, unlike in the past, when someone tested positive for HIV, that's assumed to be a death sentence, it can be managed. Yeah. So the earlier is detected, before you get to the advanced stage of AIDS, the person can be initiated on treatment and then, of course, live a productive and meaningful life like any other person. So having said that, concerning the Antiretroviral Impact Survey that the state is conducting right now, it's very, very important that we actually have this done to inform policy, program planning, and then, of course, to improve the health outcome. A lot of resources in terms of financial and human resources have been put into HIV and AIDS response, and this is based on evidence, data. And in order to review the impact of what we've achieved in the past and currently where we are, and if there's a need to change strategies, there's a need to conduct survey. The last survey was conducted in 2018, the Nigerian Impact and Survey, that put the HIV prevalence in the state at 1.4. And then that's about 7 years plus now. There's a need to look at what we've achieved. And more importantly, the world is looking at attaining global eradication of new infections of HIV by the year 2030, which the country has signed on to. So we need to look in this direction. Are we achieving the result? The 95-95 target, is there any need to address the strategy we are using? Or we are on course? So this impact survey will reveal this to us. And so this will help us even to get efficiency of the limited resources that is available for HIV response. So it's very, very important that we have the support of the community, the household that have been enlisted to participate in this survey, so that we can get the right outcome to help to inform programming.
Yes, I mean, the awareness for HIV/AIDS has been massive in Nigeria, and to a great extent very successful. However, we still have issues with stigma, you know, and that's why you see the kind of apathy that you mentioned earlier on. And this program we're talking about, it's going to provide us with kits that will allow us to do the testing at home. I also like the confidentiality part of what you are doing, that, look, everything is for you and you alone, the next person wouldn't see. But the average Nigerian that goes to the clinic, when he's coming out of the consultation room, he meets another person and he will say, this one don't know, say I get HIV. you know all that. What are we doing now to get Nigerians to understand that HIV is not a death sentence, which you mentioned? The stigma is still there. You know, how do we eradicate this stigma? Do we have an application where we can get antiretroviral drugs without being at the clinic physically? Do we have, you know, are we working remotely on this?
Okay, thank you for this very important question. It's very, very valid. Stigma is still out there. If I say we've actually eradicated it, that will amount to a lie. We're working assiduously to ensure that we increase stigma associated with HIV. Not only HIV that has stigma, STIs having the same thing. The honest truth is the fact that we have to go the route of health promotion. People taking ownership of their own health.
Sorry, let me not. But sorry for to butt in. Are we thinking of getting technology involved in this thing?
So absolutely, absolutely. One, the first thing to address stigma issue is to create awareness. Providing information to the populace. People knowing that HIV is not a death sentence. That's one of the reasons why people actually stigmatize HIV.
Yes.
That if you know your status and then you are initiated on treatment, you can live a productive life. So that will actually help to debunk the beliefs around stigma. And then what we've been doing, we've engaged the religious leaders, the community leaders, the youth leaders, to engage them, inform them, educate them. We work with the community structures so that they can educate their community members, because the facility gets people from the community. The community starts from the household to the small community where they are, and then of course the local government, the state. So we work with the different religious leaders, because we believe the religious leaders, the traditional leaders, people so much believe in them, even more than the doctors.
Oh, yes.
So we are using that structure. In terms of technology, we use the social medias. We have the champions, what do you call them? The
content creators.
Yeah, thank you. Influencers, that's the right word I'm looking for. So to be advocates, to project
But when you say influencers, is it influencers with living with HIV, or just what kind of influencers?
Both. Because you don't restrict it to only someone living with HIV. That's another form of stigma.
Well, I'm looking at a situation where, because people still go to the clinics to get their antiretroviral drugs.
Yes.
And a lot of people miss their appointments because they don't want people to see their faces. Can we order them? You understand?
The truth is the fact that for you to access the treatment, there are some basic tests you have to do, and that can not be done by proxy. So you have to be there physically. Because in medicine, you have to assess based on the baseline at the start of the treatment, and then every 6 monthly, there are some basic tests you have to conduct to see, one, the impact of the drug on the system, and then two, how responsive it is. Because there are different classes of drug that are used for the HIV management. You have the first line, the second line, and the third line. If someone fails on the first line, is moved to the second line, which we don't actually encourage. That means we are failing the program. And then if it moves to the third line, which is a cocktail of different drugs, has multiple side effects, which we don't pray for people to move into.
To that point.
So people must come in to get the baseline assessment, cancel the most important thing in initiating anybody in treatment. HIV is not emergency. It's not HIV that will kill, it's other diseases, because HIV destroys the immune system and make the person susceptible to other infections. So the baseline, the primary thing is the fact that the person must come into the facility, assess the baseline, and then identify the group of drug the person can, because it's a combination of 3 drugs in one. That's what we give to them, and then place them on it, and then monitor them. So when we start an individual on treatment, the first we give 1 month drug and give appointment, and then when we do the viral load at the 6 month and the person is stable, we can devolve the person to the community pharmacies. They don't need to come into the facility and pick up the drug in that case.
You answered my question.
Absolutely. So, we understand that this survey actually promises high resolution insight, but I'm concerned about the inherent methodology challenges, talking about potential misclassification in testing, simple bias, or logistical hurdles and all this could probably compromise, data accuracy. So what do you think we can actually do to guard against this in policy decisions or formulations, and validate and also triangulate findings, from the survey against health, other health data?
So I will start from this survey. The methodology for this survey is a household-based survey. It's a cross-sectional survey, and then it's being scientific about the whole process. The methodology is a random sampling method is adopted. We have 205 enumeration areas across the state, and then we're looking at in each of the 205 enumeration areas, we have 30 household per enumeration area, which makes a total of 6,150 households across the state. Irrespective of the number of people in each household, the survey will be involved based on the criteria, inclusion criteria, 15 to 64 years. Anybody that sleeps in that household overnight are included in the survey. So that's actually try to include everybody that is needed to be part of it, and putting science into place in terms of random sampling. And then beyond that itself, we've created awareness, looking at different structures for people in the area of bias. We know the perception of people towards that. Do mobilization, sensitize the community leaders, sensitize the religious leaders, and the youth leaders around that area, in order to build trust towards the survey, because a lot of trust versus mistrust are out there that can actually increase the rate of refusal. The rate of refusal will actually affect the outcome, which we're actually working on. We've started the community mobilization way ahead before we commence the process for the survey itself. So the outcome, we are confident and comfortable with the level of acceptance and the little rejection we are having currently. We can't rule that out.
The rejection is coming from where?
Yeah, definitely.
From wrong biases, people are having a good example facing some of their in one community. People are one household, anyway, not even the whole community, one household. One of the the respondents, having conducted hers, giving the impression that the survey is bringing about the 66 mark.
Oh, conspiracy theory.
So you understand. So we had to go back to sensitize people, and then of course, and the survey don't force people to participate.
Of course. But let's talk about this. We're looking at 20 local government, areas as well. I want to know, if the person does the test and is positive, what next? Because we also have to speak about that. Sometimes people can do the test, is positive, they start praying to God because they don't even want to take it to the hospital to say that I've done it and it's positive. So these are things that we need to look at. We also need to educate them that if it's positive, this is what you have to do. What are you guys doing, with the ART about saying that if you are positive, this is the next place to go?
Fine. Thank you. Very, very brilliant question. So now, for the be it the community, even the survey, those who tested positive, because there are community outreaches for HIV, like you rightly said, some people will not walk into the facility, despite the fact that the test is free.
Okay.
So, I mean, LSACA and then some private,
but are they doing the test in their houses, or they are coming?
There are two components. I'll address that. Because there is self-test kits which you can do in your home, comfort of your own house or anywhere you have. And then there is a rapid test which you need a prick of blood, which is being done at the facility or the community level. At the first, so now, if anybody is tested, be it the self-test kit or the rapid test kit being conducted by cancer tester and tested positive, there are different options. That we have 105 facilities across the states that provide the ART services. The person will be referred, if it's a community outreach that the person is discovered, referred to the facility for retesting. So that will confirm that the person is truly positive before initiating the person.
So are you saying that is not so accurate? Why does the person need to go and do another? Please explain to us so that we understand.
It's quality control.
What about somebody saying that, or has it ever happened that the person will do the test, it will tell you positive, and you go to the hospital and to be negative?
Yeah, well, very rare, but it's possible. I mean, it's in medicine, never say never. So the primary thing is the fact that the national guideline actually has put a structure in place to control that. We adopt the parallel vertical algorithm. So wherein the first line test, second line test, and the tiebreaker. When an individual is tested first and is tested positive, there's another line of test, and that line of test kit the person undergo immediately. And if that says the person is positive, then you assume the person is positive. You refer to the facility.
Okay.
And if that's done in the facility, it's retested in the lab too.
Okay.
And then if the first line says the person is negative, the person is free, cancelled on behavioral positive lifestyle, and then it's asked to retest 3 months. Then if the first line test is positive, the second line says negative, which is the situation you're talking about, then there's a tiebreaker.
Okay.
So which will determine whether you are going to term the person being positive or negative. So when it's tested, if it's positive, then you now say the person is positive. And it's still retested at the facility. So that will corroborate what you've gotten initially. And then that kind of person can now be initiated on treatment. So, and then beyond, there's a second component of the question you had. So for someone who did the test at home, so now how do I link myself to the facility?
To the facility,
so
very
you
true.
can walk, the person can walk into the facility to do the test, to do the rapid blood test. So that it can go through this process. Having done the oral test at home, and then the outcome will determine whether it's positive. And then if the person is still having this, what do you call it, self-stigmatization now, and then of course denial is now, the person can call 6222. For support.
6222. And the line will definitely go. Is the line already working now?
Yes.
6222.
Is at the national level.
6222. So should I just, let me try 6222 and see.
While she's doing that,
6222.
there was a time there was a proliferation of NGOs when it has to do with HIV/AIDS. At least now you know it exists.
Yes, now I know it exists. So.
Do we still have that kind of proliferation? And number two, your partners on this survey, I know the United States government is part of it, and so maybe so many others which I'm not too sure. And that's why I want to find out. We need to know your partners to know how strong this survey is and how successful we expect it to be.
Okay, thank you for that. The first part of the question, you have a lot of NGOs that work in the space of HIV. They're still there providing support. For this survey, we are not going the route of NGOs. We're working, like you said, the CDC is funding this survey through the Federal Ministry of Health, the National HIV and STI Control Program. And then the implementing partner in this is the Public Health Information Solution and the Surveillance and Solution System, RISE-3, working with the Lagos State Ministry of Health, which where I came from. So for this, there is a scientific process, there is a protocol for the survey, which is strictly adhered to, and then of course the Federal Ministry of Health, the CDC themselves are monitoring this, and then we'll have the NREC, the institution, monitoring this process. So the standard for this, so that because the outcome of this survey will shape a lot of things, will help us to know whether the prevalence, we're achieving results, the viral suppression, which is the most important thing, are we attaining the result? Is the program failing? Is the program achieving the result? And then, of course, that will help us to learn, unlearn, and relearn if there's a need to change strategies. So this is critical to us in Lagos in particular. And then, of course, because Lagos invariably represents larger percentage of the country. Absolutely. So if it gets it right in Lagos, it probably gets right in every other.
So part of the places where people that you random sample, you mentioned houses, and you said between 15 to 64. I'm also particular about what about the standard of learning. Talk about the secondary schools. We have people who are above 15 there as well, and tertiary education. Tertiary institutions, especially on February 14th. And we know the kind of atrocities that happen, while we're in school, and then what still go ahead. So the thing is, do you also reach out to younger ones and educate them about this and warn them? Because some of them, because that's teenage, is always very dangerous to control. So what kind of education do you give them, and what kind of assessment do you also give to that particular milieu?
Okay, thank you for that question. There are different strategies that we'll adopt. There is in-school youth program, there are out-of-school youth program. For the in-school youth program, the primary school, the FLH, Primary Life HIV and AIDS Education, are conducted from the secondary school, that is, which is inculcated into some of the career subjects, basic science and integrated science. Thank you. So they are being taught HIV, and they have anti-AIDS club at that level, creating awareness about the prevention. At the tertiary institution, we form anti-AIDS club there. So they have a lot of awareness creation going on amongst the students, for the student, by the student, for themselves. So they work with the Lagos State AIDS Control Agency in this. So there's a lot of awareness.
Beyond awareness, they also do follow-ups.
They are testing. When you for the national program, there is a guideline, the minimum prevention package. There are 3 components you have to access for you to say I've served you prevention services. There is a structural component, there's a biomedical, which is the testing, and then the behavioral component, counseling, and then giving you hygiene material to live adopt a positive lifestyle. All these are what is put out there when each of these interventions are being carried. You are being spoken to, you are being provided testing, you are being educated on how to adopt a positive lifestyle, and then you are provided hygiene material you can read and inform others with. So that actually goes a long way in reducing stigma, providing education, and then adopting positive, reducing the risk of exposing oneself to HIV infection. So all these are out there. And then the out-of-school youth, the artisans, we had different targeted interventions for them. So everything, every sector and groups have been targeted with different interventions to addressing
it's a fantastic one, but just quickly, let me put this there before we wrap up. A lot of people always think that HIV is gotten from sexual intercourse. We need to make them understand that, because when they say somebody has HIV, oh, this person is an ashawo. But honestly speaking, it's not all. It's true. It's not all the time that it's not there.
Totally correct.
So people.
That's a myth.
So people also have to be careful as well. Your sharp razor. You go to your barber. A lot of men are so like. I'm sure my men here have their barbing kit. You guys do, or I should buy. Okay, they all have it, so they understand. But some men, they just go to any barber, even some women, needles and everything. So let's also put that out there, that if you have HIV, it doesn't mean you are promiscuous.
So I'll tell you the 4 recognized mode of transmission. And then to address the barbing, and the Lagos State government have been doing a lot. And that's why, the last 5 years thereabouts, we've been working with the cosmetologists and the barbers, providing sterilizing machine for them, so that those who can afford to have their own barbing kits can have the one they recycle to be sterilized before they're used on them. So we're trying to make it mandatory for them to have the sterilizing kit, and then people should know at the same time too that you ask them to sterilize. If I don't have my own, before it's being used on them.
Even your nails, so many things.
The mode of transmission, like Friday says, not only through sexual intercourse. They having sexual intercourse with an infected person, unprotected sexual intercourse, will transmit it. The vertical transmission from mother to child, a positive HIV positive pregnant woman can transmit the virus to the unborn child if she didn't go through the prevention of mother to child transmission program. There is less likely 0 to 5% chance of someone who went through the PMTC program of having a child born with HIV, and that has reduced the risk of vertical transmission. And then the third is sharing sharp objects in a needle object with an infected person. And then lastly, transmitting infected blood and blood products, which is less likely in Lagos, because there is a blood transfusion policy in Lagos. Every blood that is transfused in Lagos must go through the blood,
a process.
and then must have been
But anyway, thank you so much.
Boyfriend and girlfriend will say, I need to do covenant. So
don't go and do covenant with HIV patients.
And that's why we work with the use drug and all that.
Thank you very much, Mr. Fisher. Fantastic. I wish you all the very best with this, and I'm sure that when it happens really good. We'll have you back on this table again to talk about, further ones that you'll be doing to more local governments. Thank you so much. God bless you.